MS is a rather complex disease in terms of the number of different mechanisms, of different pathology mechanisms that change over time within the same individual. So the idea is not getting a single descriptor, but rather a framework where each person living with MS can be framed based on the combination of different pathophysiologies and related clinical features.
I think that similar to other biomarkers, one key aspect to consider is that retinal changes appear similar across different MS subtypes. So it does provide clear distinctions between progressive and relapsing forms. So for me, the true value of retinal measurements becomes evident when we observe their correlation with disability.
Perhaps the actual elephant in the room in the current understanding of MS pathophysiology is aging. We don't know how the mechanisms of aging can affect and can impact on the mechanisms of MS. And we know that in medicine, 1 + 1 it's not 2, it's 3, which means that comorbidities can play a huge role in the progression of MS.
I'm Alan Thompson, Editor-in-Chief of the MS Journal, and you're listening to the ECTRIMS podcast, a new sounding board for the MS research community and the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Today's episode is part of the MS Journal Controversies in MS series. And today we're talking about defining disease subtypes in clinical practice. And I'm joined by two experts on this topic, Marcello Moccia of the Multiple Sclerosis Unit at the University of Naples in Italy, and Angela Vidal of Centre de Sclerosis Multiple de Catalunya in Spain. Currently, descriptors of multiple sclerosis are based on a combination of clinical and MRI features rather than underlying pathological mechanisms. And they include clinically isolated syndrome, relapsing-remitting, secondary, and primary progressive subtypes. However, the boundaries between these subtypes of MS are often unclear, and this has major implications for management and treatment. Within the progressive subtypes, the concept of active disease has more recently been introduced, indicating either new relapses or new lesions on MRI. Accumulating evidence suggests that the clinical course of MS is better considered as a continuum with contributions from concurrent pathophysiological processes that vary across individuals and over time. These observations encourage a new consideration of the course of MS as a spectrum based on clearly defined pathological mechanisms. New understanding of key mechanisms, underlying progression, and the availability of neuroimaging and humoral biomarkers will potentially have important implications for patient clinical care and treatment, as well as regulatory decision-making. And with that as an introduction, I'd now like to turn to our experts and put some questions to them. And my first question, which I'd put to Marcello, is why do you feel there's a need for a framework and not simply a definition of MS subtypes?
Thanks, Alan. Thanks for inviting and thanks for this question. Actually, as you mentioned, MS is a rather complex disease in terms of the number of different mechanisms, of different pathology mechanisms that change over time within the same individual. So the idea is not getting a single descriptor, but rather a framework where each person living with MS can be framed based on the combination of different pathophysiologies and related clinical features. So the idea of a framework fits the current knowledge on multiple sclerosis and on its different mechanisms.
Many thanks. Angela, is there anything you'd like to add?
Thank you, Alan and Marcello, for these insightful comments. So I agree that while the classical history-based classification of MS was really convenient and has been key to move the research forward by harmonizing patient populations for clinical trials and clinical studies, by moving towards a mechanism-driven framework to define MS subtypes, so we will be able to better define this heterogeneity of patients, and will bring us closer to apply precision medicine in MS with the potential to personalize treatment strategies and expand drug discovery.
Great, thank you very much for that. And maybe I could move on to somewhat broader question for you, Angela. What do you use in your clinical practice when you're looking at defining MS progression?
Thank you for that question. I'm afraid I'm not very original with that. So in my daily clinical practice as neurologist, defining MS progression is usually a challenging task, as you may already know. So I try to prioritize open communication with my patients, actively listening to what they tell me and keeping an ear out for alarm symptoms such as foot dragging, stumbling on stairs, and other changes in daily activities. So if these concerns do not arise spontaneously, I often engage in a direct conversation with my patients about how their current state compares to a previous point in time. So have they stopped doing certain activities? Are they finding more difficult to walk certain distances? Then, of course, I would perform a comprehensive neurological exam and observe patient's gait. However, I think that you will agree that this objective assessment is, although essential, is sometimes disappointing because usually patients enter describing their struggles and how MS is impacting in their daily lives, only to have me conclude that they seem about the same from a clinical standpoint.
No, I completely agree. I think it can often be quite challenging to be clear one way or the other. Marcello, do you want to come in on this?
Yes, just to add on, Angela, I believe that one of the main activities that I'm really thinking of in my clinical practice is the working abilities. Because my feeling is that, the ability to work, the ability of being active part of society is not only a sign of disease progression, of course, if anything changes, but it also is a social determinant of health. So it's something that can be both a consequence of disease progression and can affect itself the progression of the disease. Plus, I believe that as neurologists, we shall ask the contribution from other providers. So, for instance, in our clinical practice, we are trying to include the neuropsychologist for cognitive assessment and PROMS assessment to be done, I don't know, yearly, every 6 months, every 18 months. This is definitely to be agreed at multi-center level, but I think it's something that should be part of our clinical practice, as it is in other neurological diseases.
I suppose just thinking about the work situation, the other issue there is that sometimes unmanaged symptoms can have an impact on working ability independent of progression. And I'm thinking maybe of something like fatigue. But I also take the point that if you do regular cognitive assessments, which most of us probably don't do, you may pick up subtle change over time, which could well contribute to the definition of progression, the clinical definition. But it's not easy, and I suppose it leads us on in a way to think about what other things we might be able to do. So what one is, and to you, Marcello, how do you think MRI-based biomarkers could contribute to how we define MS progression?
I think we can look at biomarkers, MRI-based biomarkers with a perspective view. If we think of MRI-based biomarkers 20, 25 years ago, the count of lesions, the count of new lesions, that of course was accounting only for one of the components of MS, so the inflammatory component was part of the clinical practice. Of clinical trials and research mostly. Now it's fully part of clinical practice. And what we are seeing now is that other measures such as brain atrophy, spinal cord atrophy, the atrophy of different parts of the brain, cortical atrophy, thalamus atrophy. So it's quickly moving from clinical trials to clinical practice. We have contributed also to the development of pipelines and freely available tools to do automatic quantification of brain atrophy and spinal cord atrophy. So my guess is that with the current advances in spinal cord, in brain and spinal cord acquisition and processing, we shall be able to include more and more measures, MRI-based measures in our clinical practice. And these measures will be more and more sensitive to the underlying pathobiologies of MS.
Thank you for that. I mean, Angela, just thinking, listening to Marcello's answer, I mean, MRI clearly has a lot to offer, but of course, MRI is not available everywhere. And if we're looking at global definitions, access to MRI could be quite a challenge. What do you think?
Yeah, I completely agree with this point. I think that despite the valuable insights that MRI provides us, there are still some challenges in translating some of these measures into clinical practice. So, and I think we should also try to standardize acquisition protocols, analysis methods. We do not have established validated cutoffs, for example, for brain atrophy. So what's good, what's not good. So I think there's still work to do there. Also, in my opinion, I believe that volumetric measurements, despite being really, really useful in clinical trials and have provided a lot of insight in the neurodegenerative process of the disease, in the end, for me at least, is like the ultimate consequence of various pathological mechanisms. So I would like to have more prior, or being able to anticipate this damage in advance.
Okay, well, I mean, following on from that, Angela, I mean, what do you think about blood-based biomarkers? Do you think they make a contribution at the moment, or have the potential to make a contribution?
I think they have a potential for contribution. I think that now there's abundant evidence that serum neurofilament light chain, the serum neurofilament levels, we know that they reflect axonal damage, which is usually mainly driven by ongoing inflammation. We know that they are associated with relapses, MRI disease activity, and they can predict disability progression, especially in the short term. So that might be a way to detect earlier this axonal damage. But still, I think there's work to do there too.
Still quite a bit to do. Marcello, anything to add to that? Are you?
Well, neurofilaments are definitely the blood-based biomarker closer to our clinical practice, but there is a lot going on. Along with neurofilament, we have GFAP that might detect not only the damage, but the chronic inflammatory changes within the brain as a consequence of activation of the astrocytes. But thinking a bit out of the box, there is increasing evidence on genetic risk factors for worse progression. So maybe from baseline, we might be able to identify the population where some pathology mechanisms might be dominant over others. And I think this will be, a game-changing strategy, because we actually define those at risk of progression rather than those that are progressing.
Okay, thank you for that. I just staying with the same theme, Angela, what about an area you've been particularly involved in, biomarkers of optic nerve or retinal pathology? How do you think, what role might they play?
Yeah, so as you already know, I'm sure you are aware that both retinal nerve fiber layer and also the measure of the ganglion cell, measuring neurons in the retina, have been proposed as a valuable model to examine neurodegeneration in MS. I think that similar to other biomarkers, one key aspect to consider is that retinal changes appear similar across different MS subtypes. So they don't provide clear distinctions between progressive and relapsing forms. So for me, the true value of retinal measurements becomes evident when we observe their correlation with disability. And unlike MRI, I was telling before that there was no standardized cutoff value, there have been some efforts and a lot of works showing that different cutoffs can identify patients at higher risk for confirmed disability progression. So, for example, an international study led by Martinez Lapiscina within the IMSS Visual Consortium back in 2016 was able to demonstrate that a single time point retinal measure could predict higher risk of disability progression 3 to 5 years later. So this was conducted in a cohort mainly represented by relapsing forms, but we have now some preliminary data that was presented at the last ECTRIMS meeting confirming that it should be also good to identify patients at higher risk of disability progression in a pure progressive MS cohort. And in fact, if you think about it, these findings align with the observation that retinal measures mirror changes in brain and spinal cord volume, so that thinning of the retinal layers is indicative of lower brain volumes and lower spinal cord area, which I think this is really interesting. And to conclude also, or just last mention that beyond measuring progression, retinal integrity measurements have also been applied in clinical trials for neuroprotective agents. And although not successful right now, this suggests that in the future, retinal measures could play a pivotal role in monitoring various aspects of the disease.
Angela, thanks that's a really comprehensive answer. Marcello, I'm going to move on to the next question, actually, because I really it's kind of key question and not an easy one, which is around our gaps in our current knowledge in relation to mechanisms underpinning progression. So, if we're going to have a more pathologically based framework, we need to understand the pathology. So what do you feel our main gaps are at the moment?
I believe we have a number of gaps. Perhaps the actual elephant in the room in the current understanding of MS pathophysiology is aging. Our MS population, thanks to treatments, is aging and is aging relatively well, but we don't know how the mechanisms of aging can affect and can impact on the mechanisms of MS. And there is a lot of evidence, and we have also partly contributed to this evidence, that cardiovascular risk factors, for instance, that are very common in the general population and can be ideally controlled with medications, can affect the long-term progression of multiple sclerosis. But in that case, it's not only MS pathophysiology, it's a combination of the two. And we know that in medicine, 1 + 1, it's not 2, it's 3, which means that comorbidities can play a huge role in the progression of MS. So again, we need to take a step back and look at the person we have in clinic with a broader view, not just on active inflammation, chronic inflammation, neurodegeneration, but rather as the complexity of the individual that is aging with MS.
And I think this is a topic of a workshop taking place next year. So it's a really important area. Angela, is there anything you'd like to add to that?
Yeah, I mean, within the same concept, I think that we are using also measures such as, for example, neurofilaments, brain atrophy, even retinal measures that also change with age. So understanding the interplay between these effects of aging and the progression of MS, I think it's crucial.
Yeah, excellent. Another challenging question and topics that came up over and over again at ECTRIMS in Milan, which is to you, Angela, what role might worsening relating to relapses, or RAW as it's now being called, and progression independent of activity, or PIRA, what roles might they play, could they play in the development of new descriptors?
I think that traditionally relapse-independent mechanisms have been just considered the hallmark of progressive forms of the disease. But as you mentioned, there's a compelling body of evidence now challenging this notion and indicating that progression independent of relapse activity, so the so-called PIRA term, extends across the entire spectrum of the MS phenotypes, right? And there's an insightful systematic review on PIRA just published in JAMA Neurology, so I'm not going to extend on that. But these findings, for sure, they challenge the conventional clinical distinction between relapsing and progressive disease subtypes, and reinforces the need for a shift in how we classify MS disease courses. So how we should proceed with this new classification, I think it's still a matter of debate. I think both RAW and PIRA are dynamic aspects of the disease, with individual patients experiencing either multiple RAWs or PIRA events during their disease evolution. So I think I align with the vision presented by Fred Lublin in a commentary recently published in the Multiple Sclerosis Journal, and it suggests classifying patients based on their predominant manifestations at a given time, whether it's relapse predominant or PIRA predominant. And then this classification can be further modulated by additional biomarkers that can measure both inflammation and neurodegeneration.
Yes, Angela, thanks very much. So we may be doing several things in parallel. And I also think the concept of time is really important. These are dynamic phenomena, and we need to try and at least make some attempt to work out the timelines. Excellent. Now, Marcello, I'm going to ask you a slightly broader question, and it's really this: is how does a different approach to defining MS progression relate to examples in other neurological diseases? So I'm thinking of Alzheimer's or Parkinson's, where there's also been quite a lot of work, I think, in looking at new descriptors. Any thoughts on that?
Yes, I think we need to take the best from each disease to see how they have behaved in the understanding of the underlying pathophysiology. And today, we can actually have a diagnosis of Alzheimer's disease in the absence of objective symptoms. We can have someone with subjective cognitive issues who tests positive for Alzheimer's biomarkers, who tests positive on amyloid PET scan, so with using radiology and CSF-based biomarkers, not yet blood. And we can do the diagnosis. And the same applies, for instance, on Huntington disease. So we start from genetics and we do staging of the disease based on the genetic risk. And we can actually, from the genetic risk, from the number of triplets, we can predict how the disease is going to evolve. Of course, Huntington disease is a very easy disease compared to with MS. There is a clear-cut genetic mutation. But perhaps in our case, we shall combine different mechanisms and different clinical features. And this is what they are doing, for instance, with Parkinson's disease and the non-motor onset of Parkinson's disease. So a group of signs and symptoms that occur years, even decades before the motor onset of Parkinson's disease. But in that case, we have evidence that the pathology of the disease is already on, which of course changes the paradigm of neurology. Neurology started as a clinical thing. Now we need to move to biologically driven decisions. And I think that's the key.
So there is, in a way, a sense that most of the neurodegenerative conditions, and I'd include progressive MS in that, are moving towards different descriptors that are more pathologically based. And I think the idea of staging or phases is something we need to try think about incorporating into our new descriptors. Well, then let me ask you another question, which is really, I think there's a general consensus that we're going to need to think about a new way of describing this condition. But maybe to Marcello first, about your thoughts on there was a recent landscape survey which was published in MSJ. What do you think the takeaway messages from that are?
Yes, that was actually a huge effort from the International Advisory Committee on Clinical Trials in MS, and so ECTRIMS and the National MS Society. And over 500 stakeholders in the world of MS have provided their opinion, and there was a very general agreement that current clinical course descriptors for MS need to change. Of course, participants have also highlighted their doubts about the inclusion of some biomarkers over others, and definitely there are gaps and there is room for improvement. But overall, there is a general sentiment that we need to move to biologically meaningful definitions of MS progression, so that by combining the number of different biomarkers, we shall be able to frame the person with MS within the general definitions of the biology of the disease.
So overall, a consensus that we need to change, but caution about the impacts of any changes. And with that, Angela, what do you think the potential impacts of changes in the descriptors might be on, for example, treatment trials and treatment strategies?
So I think that changes in this description hold promise in transforming how we approach MS. And I think, for example, that by incorporating either laboratory or imaging biomarkers, we can better identify patients who are more likely to respond to a particular treatment. and this will increase or can lead to a more efficient and effective clinical trials. And also opens the door to a more personalized treatment strategy, so that instead of using one-size-fits-all approach, we can tailor interventions to match the right patients with the right treatments, and increasing the chances of either positive outcomes, but also reducing the exposure of those non-responders to potentially ineffective therapies and with the risk of some harm. I think that maybe this shift also, and I don't know what your opinion is, but I think that it should also lead the evolution of clinical endpoint, right? So in clinical trials, we need to move beyond the traditional clinical measures and incorporating other biomarkers or other outcomes.
Thanks for that. I mean, Marcello, I'm just thinking more broadly, again, the implications of change. What would your concerns be for patients and clinicians and drug companies in terms of licensing of drugs? Do we have concerns with that?
We do, I do. And I think it's normal. It's 20, 30 years that we have been getting used to saying relapsing, remitting, secondary progressive, primary progressive. It is somehow easy to understand to people with multiple sclerosis. So we need to be also sure that the wording that we use is appropriate for defining the pathophysiologies of the disease, is easy to understand to people with MS, and can apply to regulatory agencies. We don't want people on treatment being denied treatment because of a new definition. We just need to make sure we are able to define the pathophysiologies of the disease in the person, and that definition has implication for the overall management, which is not only about disease-modifying treatments, but it is also in referral to rehabilitation, motor rehabilitation, cognitive rehabilitation, or all healthcare needs. So there are huge implications, but also huge responsibilities.
I would completely agree. So now, as we're coming towards the end of our discussion, I'm going to ask Angela, first of all, what is your 5-year outlook on new tools which we might be able to use to help define MS progression in clinical practice?
So I think one plausible scenario within this 5-year timeline is the adoption of comprehensive digital measures, and still there's work to do there to better understand what we are measuring, cutoffs, and so on. But I think that these measures, in the end, will provide us with a more detailed information on how MS is impacting our patients. So I believe that we should be ready to use that in our clinical routine practice.
I think that's a really good idea. Marcello, anything you might add with that 5-year future look?
Well, we are actually seeing huge advances in all fields of MS. If we think of MRI, we can, for instance, talk about the iron limb lesions that have a very strong pathology correlate of chronic inflammatory activation. Or if we think of the OCT, we already have OCT machines that are able to acquire angiography data. So vessel changes in the density of vessels or the distribution of vessels that can actually precede the actual loss of neurons. And the same applies if we think on blood-based biomarkers. There are ultrasensitive methods that can detect, for instance, cytokines and small molecules that can ideally predict the dominant inflammatory components in the person with MS. So there is really a lot going on. And if we look 5 years backwards, then we can easily see how things can improve in the next 5 years.
So let me conclude by asking the two of you, and I think I know the answer, but let's see. Do you think there is a realistic likelihood of arriving at a new, more pathologically based framework over these coming years? Angela, what do you think? Are you optimistic?
I'm optimistic, yeah. So I believe there's a very realistic likelihood of arriving to a new framework for defining MS subtypes. And I think that it has also been mentioned here that while I believe this is a realistic goal, it is also important to acknowledge that there is still a significant task ahead.
Great. Marcello?
I am optimistic, and I believe we all have to be optimistic. Current clinical descriptors just describe the main clinical component of the disease. So they do not actually reflect what we know on MS at the moment. So yes, I'm optimistic that we will have a new pathologically based framework for defining MS.
Thank you for that. And I think on that positive note, we should end. So I'd like to thank you, Marcello and Angela, and thanks to everyone for listening. Once again, I'm Alan Thompson, host of the podcast episode and editor-in-chief of the MS Journal, the official journal of ECTRIMS. So the ECTRIMS podcast is produced and hosted in collaboration with two key partners, the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system, and MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is supported by an educational grant from Novartis AG, Hoffmann La Roche AG, and Alexion Pharmaceuticals. Educational grant providers have no input whatever on the podcast series content. The ECTRIMS podcast is supported by an educational grant from Hoffmann La Roche AG, Alexion Pharmaceuticals, and other grant providers. Educational grant providers have no input whatever on the podcast series content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ECTRIMS EU. Do subscribe to the ECTRIMS podcast on your favorite podcast channels and follow ECTRIMS on Twitter, LinkedIn, Facebook, and YouTube.